Welcome to Mercy Medical Center's live webinar. Today we'll be discussing the basics of colon cancer and specifically hereditary colon cancer. Joining us today is Colleen Mohr of Mercy's Cancer Genetics Program. After her discussion, Colleen will take questions from our audience. To submit your questions anytime during the discussion, go to the window in the upper right-hand corner of your screen and type in your question. If you don't see the screen, click on the orange box with white arrow. Your questions are anonymous, completely confidential. Let's get started. Colleen?
Hi, my name is Colleen Mohr, and I will be talking about the basics of colon cancer and hereditary cancers. First of all, just kind of basics on the top 5 cancers that are found in the United States. These are listed here being lung cancer, prostate cancer, breast cancer, colon, and pancreatic. So as you can tell, colon cancer is one of the top 5 that are found within the United States. Colon cancer, an estimated of close to 103,000 cases of colon and 40,000 cases of rectal cancer are expected to have occurred in 2010. It is the 3rd most common cancer in both men and women. Unfortunately, incidence rates have been increasing by 2% per year since 1994 in both men and women. Also, I just want to add that the incidence is the 3rd most common. The common for males is prostate, lung, and then colon cancer. And for women, it's breast cancer, lung, and then colon cancer. For the top deaths of cancer in the United States, lung cancer, prostate, and colon for the men. And then for women, unfortunately, it's also lung cancer, breast cancer, and then colon cancer. So colon cancer is pretty consistently with incidence and deaths of being number 3. So it's very important cancer to be aware of. Some of the signs and symptoms that someone might notice of having colorectal cancer are the following. But first of all, usually there's no signs and symptoms at early stages. Most of the time, if the colon cancer is found early, you might hear through friends and family that they found it through a routine colonoscopy screening. So sometimes when you have a colonoscopy screening that starts at the age of 50, they just might notice the colon cancer during the screening, and you may have no signs and symptoms to let you know that you have the cancer. Once the cancer is advanced, in advanced diseases, you will notice some signs and symptoms. Some of them might be some rectal bleeding. You might notice some blood in the stool. You also might notice some change in your bowel habits, whether it's diarrhea, constipation, or just a change in the normal bowel habits that you have. Also some pain, obviously, some cramping in the lower abdomen, or you just might feel like a generalized bloating or pain in the abdomen. One other symptom that is not listed here is also weight loss. One thing about weight loss is to lose weight, we all know it's pretty hard to lose weight, so you have to eat less and exercise more. And if you're not doing any of the following and you are losing weight and haven't changed how you're eating or exercising and you keep losing weight, you really need to let a healthcare professional know of this symptom because something pathologic could be going on. Not only colon cancer has signs of weight loss, but other types of cancers do too. Some of the risk factors that you might think of having an increased risk of colon cancer, number 1 is age. Increased age, increased risk of colon cancer. As you can tell, 91% of cases are diagnosed over age 50. Most of it you kind of look at also the family history. Who's in your family who's had cancer? You look at your different relatives. And when we look at it from a healthcare perspective, we look at it from 1st degree, 2nd degree, or 3rd degree relatives. Our 1st degree relatives are considered our siblings, so our brothers and sisters, and then our parents. 2nd degree relatives are so our nieces and nephews, aunts and uncles, and then our grandparents. And 3rd degree relatives, cousins, great aunts, and so forth. So look at your family history, who has cancer in it, especially if we're talking about colon cancers here today, and especially stay tuned to people with first-degree relatives with colon cancer. Modifiable risk factors, when we talk about this, is things that risk factors that we can actually modify ourselves to lower our risk, or we have them and it increases our risk of cancer. So some of those modifiable factors are obesity, diet high in processed or red meat, heavy alcohol consumption, long-term smoking, and decreased fruits and vegetables. So a lot of times in general what they say is just having a healthy diet, eating the right amount of fruits and vegetables, decreased amount, not eating red meat every single day. Certainly you do not have to cut that out. We'd love for everyone to cut out smoking for sure, but long-term smoking is an increased risk of cancer. So those are things that we can change, or you can change, to decrease your risk for cancer. So now we look at what is the difference with risk factors for hereditary cancers and those that are not considered hereditary. The symptoms of colon cancer will be the same. It could be the weight loss, the change in bowel habits, the pain. All of the symptoms of colon cancer, whether it's hereditary or not, remain the same. But some of the risk factors is what healthcare professionals should know about, and also you should be aware of. So colorectal cancer before age 50. Usually it's in the younger ages, about 40, mid-40s. Sometimes if you have hereditary cancers, a lot of times colon cancer is diagnosed. Average age of colon cancer right now is in the mid-60s or so. Colorectal polyps. You might not necessarily have more polyps with some type of syndromes, and I'll talk about this a little bit later. But if you do have polyps and it's hereditary, and you have hereditary cancers in your family, having colorectal polyps can increase your chance that those will turn into cancer down the line. Mutations related to cancers in individual or family members. Some of those besides colon cancer is number one, which you will see. But also you'll see uterine cancers, ovarian, stomach cancers, or even cancers of the urinary tract. Those are a lot of cancers to remember. The biggest one to kind of focus on is colon cancers at first. Then we look at, has anyone have a relative with this HNPCC or FAP gene mutation cancer? And what that means is hereditary non-polyposis colorectal cancer, or familial adenomatous polyposis. So those are kind of all jumbled together, but this is some of the lingo that you might hear, or hear other family members that they say that they have this type of gene or carry this type of hereditary cancers. And also, I want to add that colorectal cancer after age 50. And I did talk about with the first bullet point that it's before age 50, but as we know in medicine, there's always some shades of gray, and there isn't this automatic cutoff if you have cancer after age 50 that it's not considered hereditary. It is considered hereditary after 50 also, but especially you want to tie in a couple things like colorectal polyps within yourself or family members, or other family members have colorectal cancer. So when you add all those things together, it kind of fits into a little puzzle to say, okay, look, they have numerous risk factors that we might need to think about that they could have hereditary cancers. So how much cancer is hereditary? When we look at this slide, the green portion is sporadic cancers. And we consider sporadic cancers that happen at the usual ages, usually later in life, 60s, 70s, 80s. You're going to see a lot more when you hear of, great-grandpa Joe or Grandpa Joe in his 80s having colon cancer, is a lot more, it seems more reasonable than someone we hear in their 40s or 50s that have colon cancer or any type of cancers. So sporadic cancers tend to fit into that category. Then there's familial, which is the purple part, and that is about, I would say, 10 to 20%. And sporadic cancers, I don't think I said, is anywhere from 70 to 80%. So familial, which means it's in the family, but right now we're not sure if it's hereditary. Hereditary is in the small piece of the pie. It's only about 5 to 10% of cancers. So surprisingly, a lot of people that I see, and I think other healthcare providers that they see, is they come in and let's say they have a family member with colon cancer, and they'll say, well, it's in the family, it's hereditary, I'm going to get colon cancer. And that's not necessarily true. Just because you do have other family members, it does increase your risk, but it's not necessarily hereditary. And I'll talk later on how we figure out if it's hereditary, and usually you have to go through some type of genetic testing. So I will start, I'm going to talk about two of the syndromes, and it's HNPCC and the FAP that I talked about earlier. And there are some other types that tend to be a little bit more rare, but the HNPCC for hereditary cancers is the most common one that we see in the healthcare profession. So the mutation is an MLH1, MSH2, MSH6, or a PMS2 gene. And a lot of people are like, what the heck does this mean? And those are genes that we normally have in our body, and they are mutated, and they're called these mismatch repair genes. And this type of syndrome is also called Lynch syndrome. And it's an inherited condition that increases your risk of colon cancer and other types of cancers. And these are the genes, if we inherit a non-working copy, these are the genes that can cause an increased risk of cancer. And there it is, the mismatch repair genes. And what this means is all of these genes are involved with repair of mistakes. When our DNA, when we are being born, or not being born, when we're being made in utero, our DNA is copied. And so what happens during this process is mutations or mistakes can occur. And what these guys do is they go in there and they look like, okay, wait, there's a mistake, something's not working right, we need to fix them. And so that's what they do. And if we inherit a non-working copy of one of these genes, they can't do their job, and so cancer can grow uncontrollably. And that's basically what cancer is. It's uncontrollably cells that we can't control. And so these genes go in there and they try to control all these cells from just multiplying and multiplying. And so if we inherit that non-working copy, they can't do their job, and so that's why the cancer keeps growing. The cells just keep growing. And so also, not only colon cancer, these mutations may cause other types of HNPCC-related cancers. Some of those, like I said earlier, the colon cancer. Uterine cancer is also a big one that you'll find in HNPCC cancers. Uterine cancer, endometrial cancer is another name for uterine cancer. You might hear family members talking about that. So colon and uterine are kind of the top ones. Then we can run into like stomach cancer, ovarian cancer, kidney cancers, maybe even a brain cancer, but those are much less common as much as colon and uterine you tend to find. Now this type of syndrome is called in an autosomal dominant type pattern. And basically what this means is it has to be in every generation for it to be passed down. So if I have colon cancer and I'm tested to see if I have hereditary, this HNPCC, and I'm positive, I have to have inherited it from my birth mom and dad, one of the two. So it doesn't distinguish, well, you have to be on the female side because I'm a female, or it has to be on the male side if you're a male. Absolutely not. You get 50% from your mom and your dad. So it comes from your mother or your father, and let's just pretend it came from my dad's side. Then it has to come from his parents. So it has to be in every generation for it to be passed down. The only way we can't inherit it, let's say my dad has colon cancer, he tested positive, then I tested and I'm negative, I cannot pass it down to my children. It won't come back 2 generations down the line or anything like that. So once you don't inherit it, it stops, and that's what's called the autosomal dominant type pattern. Okay, so now we look at hereditary versus sporadic colorectal cancer for the HNPCC. So we have colorectal cancer, as you can tell, the risk can be up to 80%, and this is a lifetime risk of up to 70, 75 years old, we'll say. So if someone has this hereditary HNPCC mutation, of one of those mutations I talked about in the previous slide, you could possibly have up to an 80% chance of developing colorectal cancer. Normally, the general population is a lot lower than that. It could be anywhere around 2% or so. Endometrial cancer, 42 to 61% chance. Normally, uterine cancer is about 1.5%. Stomach cancer on the slide hits about 13%. That's a pretty rare condition. It's around 1%. And ovarian cancer is only about 12% risk, but normally it's around 2%. So as you can tell, you don't have to remember all these percentages, but just knowing that your risk is that much higher than the general population of having cancer. It does not mean you automatically will have cancer if you have one of these mutations, but your cancer risk is a lot higher. So now I'll talk about the familial adenomatous polyposis, which is considered the most classic type of syndrome with this in this area, and it's called FAP, you'll hear me talking about, or attenuated polyposis, and that's called AFAP syndrome. And these are mutations in the APC gene. And this is another rare inherited condition that is characterized by early onset colon cancer. This one, compared to the HNPCC, tends to be a little bit more rare, I should say, than the HNPCC of hereditary cancers. That one's a little bit more common than this one tends to be. So basically, what does this gene do? We know the other genes, they're called mismatch repair genes, and they kind of go in and put Band-Aids on stuff and fix all the genes. But this one, this stabilizes how fast the cells grow. That kind of slows down the process. If they see some cells kind of growing really fast, and those cancer cells really like to grow fast, these guys go in there and they just kind of slow it down and stabilize how fast cells grow. So once again, the same scenario. If you have a mutation on one of these genes, or the APC gene, they can't do its job, and so that's how cancer grows. So we call it a mutation or a mistake on the gene, and then cancer tends to grow. So one symptom that distinguishes from the HNPCC is multiple polyps. Multiple polyps, I'm talking about hundreds to even thousands of polyps. So someone would do a colonoscopy and they would see lots and lots of polyps, and someone probably would be having some symptoms, GI symptoms related to having a lot of these polyps. The average age for colon cancer for these APC can be 39 years old, so it's very, very young, and this is often caught a lot younger also. Some other cancers that also are related with this is pancreatic cancer, some thyroid cancers, stomach cancers, and brain cancers. And not necessarily if you see this in your family, like, oh my gosh, Uncle Charlie had pancreatic cancer, we must have, and I have colon cancer, we must have this. It's not that. You really need to look at the whole family tree, the whole scenario, who had what, and a lot of times we need pathology to kind of really figure it out, what a family looks like, and see if they kind of fit in these types of syndromes. Now the attenuated one, the AFAP, they might not have as many polyps as the thousands or hundreds. There might be a little bit less. And also the cancer tends to happen a little bit later, maybe in mid-50s than in the 30s compared to with the colon cancer. So that one tends to be a little bit less severe than the FAP. So with here, as you can tell, if you have a mutation on the APC gene, you will probably get colon cancer in your lifetime. It is close to 100% if you have it in the FAP that you will develop colon cancer. if you don't start screening early and start prevention compared to the general population, again, the sporadic population, that purple slide. The attenuated, like we talked about, you have less polyps. The cancer happens a little bit later in life. Theirs is maybe up to around an 80% chance. Still pretty high when comparing your normal sporadic risk and having an 80% risk by the time you're 70, 75 years old. So what do you do? How do you manage HNPCC or the FAP or AFAP if you are a mutation carrier? So what you would do is increase surveillance. Number one, we want to start early. Our number one goal is prevention of cancer. So if we know it's in your family, we want to try to get the people that do not have cancer already, do some testing, and then try to get them their surveillance early. Because a lot of times you cannot get the colonoscopies until you're 50 years old. That's the baseline right now that insurances, Medicare, all those companies pay for them. So if you do have a mutation, you can get a lot of those tests paid for much earlier. So if I say that I'm an HNPCC carrier, then my insurance should pay for a colonoscopy much earlier than 50 years old. So that's the goal of the increased surveillance. In these FAP families, you can start colonoscopies as young as 20 and 25 years old, because sometimes those polyps are found even in teens and then certainly develop. The older you get, the more polyps you develop with the FAP. And also with the HNPCC, the polyps, not necessarily more, but I think I mentioned previously that they do tend to happen a little bit earlier in life. You tend to see polyps maybe in their 40s, which isn't as common to see polyps in someone. So that's why it's, once again, important to get that colonoscopy early. And also within your family, let's say my dad was diagnosed with colon cancer at 50 years old. I'm not going to wait till 50 to have my first colonoscopy. I need to start that colonoscopy 5 to 10 years earlier than the youngest family member who had colon cancer in my family. And once again, it could be even earlier with the FAP families, depending on the age of the first polyp. And also with FAP, they might do a sigmoidoscopy beginning as young as 10 to 12 years old, and that's done annually. So that's a very, very young age. And FAP is very unique. I just want to add that compared to the HNPCC. So the screening sometimes can be a lot different and more aggressive than the HNPCC. I feel like I'm saying the alphabet all the time here. Okay, so my next one is talking about continuing on surveillance. So how we talked about is uterine cancer, remember, and endometrial cancer is also involved with this. So you need to do your follow-up with your family practitioner, gynecologist, to do those exams. Pap and pelvic exams are a must. You must do this once or twice a year. If uterine and ovarian cancer are common, you need to go in and get those screening. Transvaginal ultrasounds, they do this once or twice a year, and basically they can do this in the physician's offices, and they can visualize your ovaries to see if there's any abnormalities. Also doing an endometrial uterine tissue sample if someone still has their uterus. Sometimes they'll test the tissue just to make sure that there's no cancer growing. A CA-125 test, this is a biomarker. If it increases, it might say that there's a ovarian cancer growing in the ovaries. Unfortunately, this is not a standard screening. If we go in for our yearly physical, you think, well, why don't I do that for my yearly physical when I'm going for my mammogram or pelvic and pap exam? Is because other things can also elevate it, like endometriosis, even uterine fibroids can increase it. So other things can trigger it to increase. So basically, this is just like a little marker along with other pieces of the puzzle that we might look at, but it's just a blood test that we might have drawn. Also, all these tests should be done every 1 to 2 years. So then we look at genetic appointments. So you're looking back, you look at some of the risk factors, and then you tend to think, okay, wait a minute. It looks like I have an increased risk of some of this type of syndrome. So what am I going to do? I need to make a genetic appointment. And here at Mercy, we have our cancer genetic and risk assessment program. Also, we just don't look at just genetics and we do testing. We also look at your cancer risk. What is your risk for cancer? Do you kind of fall into the sporadic category, familial cancers, or even hereditary cancers? So those are the things you come in and have an appointment with us, and we can sit down and discuss it. It's about an hour-long consultation. You do not need a referral. You can refer yourself. Family members can refer you. You can be referred by a physician or any other healthcare provider. The service is free to patients. It's part of our cancer program here. We do not charge for the consultation to come in and discuss your family history and personal history. Also, we suggest maybe bringing in a family or a friend to kind of come in. It's a lot of information to go into over an hour, and sometimes you might just feel overwhelmed or have a lot of other things that you're thinking about, and sometimes having a friend with you or a family member, and then you can leave and also talk about things that were mentioned. Number one is a personal and family history. This is probably one of the most important things we discuss during your visit. And I suggest before people come in to visit with us, obviously you're going to know your personal history of cancer, when you were diagnosed, or if you don't have any cancer. You don't have to have a cancer diagnosis to come in for a genetic consultation. But we do want to know the family history. So talk to other family members when you come in. If you know your grandma had colon cancer, find out how old was she, Mom, when she had colon cancer, and what kind of treatment did she have? Did she have surgery? Did she have chemotherapy, radiation? All those things are really important for us to find out. If you have any medical records for yourself or other family members, also bring those in with you too. We like to figure out what type of cancers everyone has and verify. A lot of times family members may think they had colon cancer, but when we actually get the pathology, they might have had some other cancer, like gallbladder cancer or something along those lines. So a lot of times family assume it's a cancer, but when we really get the pathology, it may not be the cancer that we think. And that's a good thing, because then it might decrease your risk of some hereditary type of syndrome. And then I talk about what hereditary cancer is. I'm not going to go into this. I kind of already discussed it early, but kind of the same thing, a little bit more in depth about hereditary cancers and sporadic cancers and what the differences are. And also, we'll talk about GenM are doing them here in the state of Iowa, so we send them out, and they test to see if you have one of the mutations on those genes that I talked about earlier. And that's basically what the test is. They want to see, they look at those genes to see if you have a mutation. The genetic test, once again, does not tell you that you have cancer. It just tells you if you have a mutation. And remember that mutation means that you have an increased risk of cancer, or if you already have cancer, obviously, you still have an even higher risk of cancer. The cost for these genetic tests are not cheap. This is not free and part of Mercy. It's through a lab, an outside lab, and it can cost thousands of dollars, and we can give you specifics on that. But most insurances do pay for most of it, if not all of it. Medicaid, Medicare, private insurances are all covering these testing. It's actually becoming more and more standard of care for people who have had cancer, family history of cancer. They really look at family history because the goal is to prevent the cancer. And hopefully that will be cheaper in the end than actually treating the cancer. As we know, chemotherapies and all that could be very expensive. The test results usually take about 2 weeks to come back after you do the testing. And so we do the testing, and then we have you come back, we talk to you over the phone, and we go over your test results, whether they're positive or negative or uncertain variant. And I'll talk about that, I think, in the next couple slides. And then we can discuss what's the next plan. Number one thing about genetic testing, it's very important. Why do you want to test? What are you going to do? You have to think of all the information that was given to you, and what are you going to do with this information? If you're going to test and you're going to find out, but you're not going to get a colonoscopy, you're not going to go visit your doctor, kind of not a good idea to go through all the genetic testing. The number one reason is, what are you going to do and what changes can you do to better your health and decrease your risk for cancer? Okay, so now the benefits. So the benefits of going through testing are the knowledge of knowing, and that's just what I talked about, the knowledge of knowing this information, the feeling of empowerment. What are you going to do to decrease your risk? You're going to increase surveillance. Hopefully, knowing this information will reduce anxiety and stress, not increase anxiety and stress, because now you know why there's cancer in your family. There's actually a reason. It's hereditary. So there's things that you can do to decrease your chance of reoccurrence or decrease your chance of having cancer. One other thing, it's important for other family members to know. Obviously, other people, you're very concerned about your children, grandchildren. So remember, if you are diagnosed with having a mutation, your children also have a 50% chance. If you have 3 children, all of them can have the mutation, 1 out of 3, 2 out of the 2, or maybe no one would have it. Really is 50% chance. There's no rhyme or reason. Doesn't matter, once again, if you're male, female, or anything. Also, the benefits, sometimes people were just diagnosed with cancer. They go through genetic testing, and this might make some surgical decision making. Maybe how much colon is taken out before their surgery. Maybe they might take out a little bit more than they were before because now someone knows that they have a mutation. Some of the limitations that some people might feel is testing does not detect all causes of cancer or finds other mutations. It's specifically, once again, just going to look at those mutations. We only look at those specific ones, do not look at other ones. And sometimes there's other mutations out there that we just haven't figured out yet. So as we know, the healthcare field is constantly changing. There's so much research going on. So in another 10 to 15 years, there might be another one of those HNPCC genes than just the 4 of them that I talked about earlier. The test results that come back may not produce the results you're looking for. Some people, believe it or not, get a little bit disappointed if their test comes back negative. And at first I was kind of like, well, why would they be sad that they have a negative mutation? Number one is it doesn't answer those questions. All of us want to know the reason why we develop cancer. So if it comes back negative, it doesn't say, well, why am I 45 years old? Why did I develop cancer? Or why are 2 of my siblings have cancer and my mom have colon cancer and we all test negative? And that's a very frustrating thing to figure out, like, well, what are my chances now? What do I have to do? And we know we don't have a mutation. And it's just like we said, you possibly can have another mutation in 10 or 15 years once we get more research done. And an unknown clinical significance, that just kind of means they found a mistake there, that mistake, a mutation, but it seems like that gene's still working right. It looks like the gene might still be doing its job. It's stopping the cancer. It's fixing the cancer, stopping it from growing. So further research is, once again, need to know on these unknown clinical significance. So there's 3 results that are to come back if you do go through genetic testing, and those are the 3. Next limitation is testing of minors. With the HNPCC gene, obviously we're going to test people early because we talked about as young as 10 or 12, teens, 20s, they're going to have some polyps. So testing we do on minors for some of these colon cancers. HNPCC we might not test as young as teens, but probably in the 20s it's important to maybe go through testing so then they can start the prevention a little bit earlier. But we really want the older people, people to be a little bit older so they can make informed decisions and know what they're going to have to do and make decisions about their own health care. Some other types of syndromes not related to colon cancer, sometimes we won't test minors because there wouldn't be anything different that we would do. If there's some health care surveillance that we will start with minors, then we'll do the testing. And also, it's a family affair. Mutations are passed on in the family, how we talked about, the autosomal dominant type pattern. It has to be in every generation to be passed down. Testing is the only way to accurately identify mutation carriers. Sometimes with those APC families with all those thousands of polyps, physicians will go in and do the colonoscopy, and it's pretty classic signs, and they'll say, oh, this has to be an APC family. So sometimes it's clinically diagnosed, but definitely genetic testing is the accurate way to know someone is a mutation carrier. And it's important to share these test results with family members, not only the positive, but also the negative test results. And you don't have to share this information. It's your personal information, but it is helpful. Let's say I'm 50 years old, I passed away of colon cancer, and I have a niece, and she went in for her checkup, and she's like, oh, my aunt just unfortunately passed away, 50 years old. They might say, hey, did she ever have testing? Did she ever do this HNPCC? And those are things that you can let them know about. Hey, I've already had this testing. These are the mutations I tested for. So when she gets older, then she knows in 15 years that she might need another test. So it's important to share this information, I think, with other family members along the way. And that's it. We'll just tie it up with some questions from anyone out there.
Thank you, Colleen. Very, very interesting information that you shared with us. To remind our listeners, excuse me, questions can be submitted from the box in the upper right-hand corner of the screen. And we can begin with our first question. How far back should you examine your family history?
Usually we say about 3 generations. So if I came in for testing, we want my mom, we want her brothers and sisters, so aunts and uncles, even cousins on that side, and then up to the grandparents. Sometimes once you get into the grandparents, things become a little bit vague. Hopefully the older we get, the more information we'll have. But way back when, like my grandparents, sometimes if they died young, we don't actually know what type of cancer they had. They might just say, oh, it was in the stomach or it was in the abdomen area, so we're not sure if it was ovarian cancer or colon cancer, but we will go up to that ages, and even great aunts and uncles if you have. The more information you have, the better it is.
Good point about the older generations not really knowing that type of cancer. Okay, questions came in. I have a sister that has Crohn's, and I have celiac. What are the odds of either one of us getting colon cancer?
You know, unfortunately, that is not my expertise on what the risk of Crohn's and celiac disease. If I can remember way back when, I think Crohn's does have an increased risk of cancer. I don't want to say that for sure, but as having an increased risk of hereditary cancer, Crohn's and celiac are not part of that.
The question here, why is the incidence of colon cancer increasing with all the surveillance that is now available?
I know, that is an interesting point, and we do think about that, but also we think, okay, as more people getting surveillance and getting their colonoscopies earlier, so we're catching it earlier, and maybe that's why the incidence is increasing. And a lot of it has to do with diet also. Are we eating more processed food, more fast foods? Are those increasing the risk? And we have just more environmental risk factors.
We have a question about insurance. Can the results of genetic testing be considered a pre-existing condition for health or life insurance?
No, that is a good point, and insurances cannot use this information as a pre-existing condition to set policy rates, to drop you from your policy. We do have federal laws and state laws that protect people from this information. Cancer, unfortunately, is considered a pre-existing condition, but genetic testing is not. So then if if someone, we have the GINA Act, which is a federal act that was just passed, I want to say about a year ago, and that protects people from any type of genetic discrimination, testing of any of those sorts. Iowa and each state has their own state laws that also protect people from any type of insurance discrimination. Iowa specifically has state laws for people with group health insurance and employer discrimination that they cannot use genetic testing for any types of that type of discrimination. And if you do experience that or are nervous about it, please feel free to talk with me and we can get you the help that you need.
Okay, so that should not be considered a deterrent in
right.
getting tested. Okay, we have another question. We have a history of polyps in our family but no cancer. Is there a connection, and should we be tested earlier, or even our children, should they be tested?
Yes, usually with an HNPCC or even the FAP, that one's very extreme. The polyps are caught a lot earlier, even teens and 20s. But with the HNPCC, polyps do tend to happen less than 50 years old. It's not as common when someone in their 40s or especially in their 30s have polyps. It is a big red flag that maybe something else is going on within the family. So but a lot of times we're not catching them until, let's say, you were 50 and had your first colonoscopy and there were some polyps. So maybe that polyp could have been there earlier. So it might be something for them to talk with their healthcare provider about maybe starting it a little bit earlier, at least get a baseline in their late 40s or so.
What comes first, a colonoscopy or genetic testing?
I would say, well, it kind of depends on the patient and the scenario. If you're 50 and never had a colonoscopy, you definitely need to get into your healthcare provider and have a colonoscopy. A lot of times, but let's say someone's in their 40s and a lot of family members had colon cancer, parents had colon cancer, and they have some concerns, we can certainly see them and then get them on their way to get a colonoscopy and start their screening a little bit earlier.
Another question, can all cancers be tested genetically?
There are some other types of cancer syndromes out there. Some are really rare, some are a little bit more common. The most common ones that we do test are obviously the ones I just mentioned, especially the HNPCC with the colon cancer and uterine cancer. Also a big one that we do testing for is breast cancer. It's the BRCA1 and BRCA2 gene. Those are the two genes that increase risk of cancer in women. And breast cancer, ovarian cancer in a family, those are kind of what we look at to see if someone might be at an increased risk. I imagine down the line in future years, more and more genetics we're going to find out and have other cancers that we're going to be able to find the mutation and pinpoint it.
Good point. I'm sure that will be true. How long has Mercy been doing genetic testing?
Mercy, we are approaching our 5-year mark of doing cancer genetic testing here at Mercy.
I believe we may have covered all the questions that have been submitted to us, but if you have additional questions, please call 319-221-8689. Now, a tape of this program will be available at www.mercycare.org/live, and you can check this website for information about future webinars. Our next webinar will be Tuesday, April 12th at noon. Susie Kilberg, Chemical Dependency Counselor at Mercy Sedlicek Center, will be discussing alcohol awareness. And then Susie will take your questions live after her presentation.